Assalamu alaikum everyone. I hope you all are good. First of all, I want to thanks all of you for inviting me here and giving me a chance to share my experience what I'm learning here in Australia. I'm Dr. Farhana Younas, and at the moment I'm working in Quantum Radiology, Sydney, and I'm working as a part of pain management team in Quantum Radiology since last 4 years. So, so the topic of today's presentation is role of interventional radiologist in pain management of patients. Let's start the presentation. Since most of the slides and most of the material which I am using in this presentation is taken from quantum radiology, so I want to acknowledge the quantum radiology, and I also want to say thanks to my colleagues, Dr. Sandeep and Dr. Prasad, who helped me to prepare this presentation. Okay, so this look like a busy slide, but I will not go into the detail of this slide. This is actually a study which was done by Pain Australia, and I want to highlight only few things in this slide. That there are pain is a presentation of pain, but there are some other clinical presentations for pain as well. Like from we can see that 37 of patients with pain they can present with depression, and 25% of patients they can present with anxiety as well. And once after the multidisciplinary pain treatment, the 57% of patients they actually show improvement in their depression, and 41% of patients they actually show improvement in their anxiety. And since most of these patients before the multidisciplinary pain management were treated with opioids, 63% were using opioid medication, but after using the multidisciplinary pain treatment approach, almost almost all of the patients they were able to reduce their opioid dose by 50%. So this is just a type of pain. So acute pain is any pain up to 3 to 6 months is acute pain, and any pain more than longer duration is chronic pain. Acute and chronic, as you all know, it's a flare up of the acute pain at the background of chronic pain. So pain is a complex syndrome, and it's difficult to treat. It's not only one clinical presentation. It's a complex syndrome, and because of the increasing medical advancements, the number of patients with the chronic diseases they are actually more in our public health system. And since they were dependent on opioids, so the opioid use disorder is one of the major potential lethal public health concern for most of the Western countries. So interventional radiologists, they are trained to perform the minimally invasive procedures, and the best thing about these procedures that there is negligible downtime and there is negligible post-procedure pain. So it can help to reduce the use of opioids in patients, especially who are in chronic diseases. So there are different ways to manage the pain. So definitely the best approach is multidisciplinary team approach to manage the pain. And there are these are the different specialties which are included in the multidisciplinary team. Definitely GP is the first contact of all the patients to the public health system. Then the pain specialists, they include an anesthesiologist, rheumatologist, orthopedic surgeon, neurosurgeon, and radiologist. And definitely the multidisciplinary team cannot be completed without the help of our allied health professionals like physiotherapist, chiropractor, natural therapist, and acupuncture and podiatrist. So managing what are our treatment goals? Treatment is not we cannot actually um, um, uh, take the pain to the zero level. So the treatment of the goal of treatment is to improve the level of activity and to relieve pain to a tolerable level. So this is a slide. This again looks quite busy slide, but the slide is to give to highlight the importance of educating the patient that injection is very important to treat the acute pain. But the more important part is that you after the injection you have to take care of your joint or your spine wherever we are injecting, and educating the patient that doing some some exercises and swimming or walking and gentle exercises. They are really good, because most of the patient, when they are coming to you for pain treatment, they think that they have to rest after that. But resting for short period is good, but resting for long period is actually bad for the pain, because the research have shown that regular exercise can diminish pain in long term by improving the muscle tone and strength. And what we do in our practice, while we enter the room for the injection, we while preparing for the injection, we start educating the patient that you have to do some regular exercise, or stretches exercise, and you have to see your physiotherapist after this injection, if you want these injection, because if you are not going to take care of your joint or your spine, you may need these injections very often. So this is a very important part of treatment, to educate the patients about the importance of exercise. So what are the causes of pain? As we all know, the musculoskeletal pain, the neural pain, and the others. So moving on to our musculoskeletal injections. So this is a long list of injections which we are performing here in Australia. And if we start from the upper limb, the subdeltoid, and from the upper limb, I will start from the shoulder joint. I think the subdeltoid bursa injection, I think it's the most commonest injection we are performing here in our practice, and moreover in Australia, because shoulder, I think, is the a most used joint. And since the subdeltoid bursa is a narrow space, and because of the higher athletic activities, all the activities which actually include the overhead movement of the shoulder, they cause inflammation of the subdeltoid bursa. So sublunar versus then acromioclavicular joint injection we can do. Then glenohumeral joint injection can be done for the osteoarthritis and for the frozen shoulder. Moving from the shoulder to the elbow, around the elbow, we do the tennis elbow, that is a lateral epicondylitis. Is actually we give injection just superficial to the common extensor tendon. The most important thing is that never inject into the tendon. We always inject on the tendon, even if the tendon is tendinotic. So it's a study that even you inject on the tendon, they will help improving the pain of the tendinosis as well. Then is the golfer's elbow. Golfer's elbow is the common flexor tendon, which is attached on the medial humeral epicondyle, and that's also known as medial epicondylitis. We inject again on the common flexor tendon sheath. Then other injection we can do around the elbow is the cubital tunnel injection. Uh, we all know that ulnar nerve is present within the cubital tunnel, and if there is ulnar nerve neuritis, we can give injection alongside the nerve, just like in carpal tunnel. But before going for the cubital tunnel injection, we usually perform MRI before that, because there can be some other cause. Since ulnar nerve neuritis is not a very common condition, if the patient has symptoms of ulnar nerve neuritis, we usually perform MRI first, to rule out any other cause of ulnar nerve compression, and then we go for injection into the cubital tunnel. And the olecranon and bursa I think is quite inflamed. It's a common bursa to be get inflamed, and we inject into the olecranon and bursa. The injection is pretty straightforward, because olecranon and bursa is a very superficial bursa, so it's easy. Then moving on to the wrist, Dequarian stenosynovitis is the synovitis of the tendon sheath of abductor pollicis longus and extensor pollicis brevis tendon. So this is the first group of muscles on the dorsal surface of wrist. Um, Dequarian stenosynovitis. Then we can inject trigger finger. Trigger finger is actually the thickening of the pulley which support the flexor tendon of fingers. So it can be done in any finger, because all flexor tendons, and the one thing is that there can be only thickening of the pulley, but sometimes because the pulley is thickened and the tendon is growing underneath that pulley, so there may be some tenosynovitis of flexor tendon as well. So we can inject into trigger finger A1 pulley. And then the other injection we can do around the wrist is carpal tunnel syndrome. That is when the median nerve is being compressed within the carpal tunnel. As we all know that carpal tunnel is a closed space, and which is bounded posteriorly by the radius and ulna and anteriorly by the flexor retinaculum. So whenever if the pressure is high in that space, it can cause compression of the median nerve, leading to carpal tunnel syndrome. So we can inject into carpal tunnel. Moving on to the lower limb injections, which the first injection we do around the lower limb. So lower limb, I will start from the hip joint. So trochanteric bursa injection. Trochanteric bursa is the bursa which is present on the greater trochanter of femur, just under the insertion of gluteus medius and gluteus minimus tendon. Then other bursa we can inject around the hip joint is ischial bursa. Ischial bursa, we all know that it's present on the ischial tuberosity underneath the insertion of hamstring tendons. Then moving on to the knee joint, we can give injection into the knee joint. And there are some bursas around the knee joint where we can inject if those bursas are inflamed. And one of these is Pet-Sensorin bursa, present on the medial aspect of the knee, between the sartorius and semitendinosus and gracilis tendons. Then around the prepatellar bursa, it can be inflamed and we can inject into that bursa. And another thing, if the bursa is inflamed and there's a lot of fluid, what we do, we usually first aspirate the fluid and then we inject the steroids into that area. And another thing we can do around the knee joint is the Baker cyst aspiration and injection. Then moving on to the foot, I think the most common injection which we perform around the foot is a plantar fascia injection. Plantar fascia is quite a common condition because many patients, they have the plantar spur, and when there is extra spur on the plantar surface of the calcaneum, it keep on pressing on the plantar fascia, leading to inflammation of plantar fascia. I think around the foot, it is the most common injection which we usually perform. And again, we do not inject into the fascia; we inject at the top of fascia. Then the other common injection we can perform around the ankle is at the back of ankle. That's the Achilles tendon. Achilles tendon, we all know that it is present at the back of um, our ankle, and there is a bursa underneath the insertion of Achilles. That's the retrocalcaneal bursa. So sometimes both of these conditions present, like there is inflammation of the Achilles tendon, and there is retrocalcaneal bursitis as well. So what we do, we inject part of injection along superficial to the Achilles tendon and part of injection into the retrocalcaneal bursa to make it more effective. But sometimes if there is only Achilles tendinitis, then we only inject superficial to the Achilles tendon. Then first tarsometatarsal joint is the most affected joint in the foot by the osteoarthritis or gout arthritis, anything. So we can inject into that injection, and this injection is pretty straightforward. Under ultrasound guidance, you can just see the joint and inject into the joint. The other bursa we can inject around the uh, foot is intermetatarsal bursa injections, and then the lateral femoral cutaneous nerve injection. Some of our colleagues, they do perform these peripheral nerve injections, not all of us, but lateral femoral cutaneous nerve, most of the time these nerve blocks, peripheral nerve blocks, they are done by anesthesiologist. But some the nerves which are easily accessible to our ultrasound, we can perform. So lateral femoral cutaneous nerve, as you all know, is actually passes over the anterior superior iliac spine region. And if some specialists, they refer to us and they know that it's a lateral femoral cutaneous nerve problem, then we can inject in that area. And in the scalp, we can inject in the we can do the greater occipital nerve injection as well. As the greater occipital nerve, the landmark is between the mastoid and the internal occipital protuberance. It's two-third and one-third distance, and greater occipital nerve is usually present medial to the to the occipital artery. So with the ultrasound, we can easily find the occipital artery, and then the nerve is always medial to the artery, so we can inject along the greater occipital nerve, and it's really helpful in some cases of migraine. So what is bursitis? So bursa is a closed fluid-filled sac that actually work as a cushion or gliding surface between the tendon and bone, because the tendons, when they attach on the bones along the big joints, and because of the movement around the joints, these tendons, they are prone to wear and tear. But the purpose of bursa is to protect that tendon. But when that bursa is inflamed, so there is pain. The pain is not only in that area, but the pain actually goes along the all of those muscles as well. That's why the pain of bursa is always very severe. Okay, and the major bursas, they are located next to tendons near the large joints such as shoulder, elbow, hips, and knees. So I think I will spend a little bit more time on the subacromial subdural bursa, because as I have told you, this is the biggest bursa, and this is most commonly inflamed bursa of the body as well. So this is present. So what about the subacromial space? Subacromial space is actually a very narrow space between the acromion and humeral head. So these are two bones present, acromion and humeral head, and so this is a small tunnel, and in this tunnel there are rotator cuff tendons. And to protect the rotator cuff tendons from the effect of this bone, there is a bursa at the top of rotator cuff tendon. The purpose of this bursa is to protect the tendon from the effect of acromion. Especially, this tunnel actually becomes more shorter when there is overhead activity. When your shoulder is abducted more than 90 degree, this tunnel gets more narrow, and the purpose of this bursa is to protect the rotator cuff tendons. But when this bursa is inflamed, there is pain not only in this location but in all the rotator cuff tendons and all the rotator cuff muscles. So pain goes along here, along the subscapularis tendon, pain goes along supraspinatus, pain and goes along infraspinatus and teres tendon. So bursa pain is usually very severe, and but with the help of injection, we see very good results in a subarachnoid bursitis injection. So cortisone injection can be incredibly helpful at limiting the acute inflammatory process and allowing the patient to begin therapy. So again, I want to highlight that injections are there uh, to reduce the acute inflammatory process, but in the long run, the patient has to do exercises and stretches, and they have to tone up their muscles um, um, in future. It is important to participate in therapy and exercises even if the shoulder feels better after the injection. This is what usually we teach the patient, that after the injection you start feeling better. But that doesn't mean that you are okay and you are going to stop all of your treatment. No, once your pain is okay, then you have to go to physiotherapist and you have to go for stretches and exercises to prevent the recurrence of symptoms. Subacromial subdural bursa, before the use of ultrasound, the bursa injection was usually done as a blind. So there are various studies about the results of subdural bursa injection. Some studies shows a very good response to injections, but some study shows a bad response as well. And I think the cause of the bad response is because of the um, um, that it blind subacromial injections can miss the bursa in expert hands in 30% of patients. So that was the main reason. So ultrasound, the use of ultrasound is not only to inject but to diagnose the problem as well, because sometimes the patient can be having osteoarthritis, patient can have frozen shoulder, patient can have bursa. So all these three things can be there together, or one of them can be there together, and sometimes the clinical picture is very vague, and we cannot decide what actually causing the pain. So ultrasound is really important to diagnose the bursitis first, and then to inject. So this is our all the preparation for the injection. The injection is pretty straightforward. We usually use 1 ml of celestone. Celestone is acrylic dexamethasone, and for the bursa injection, for the bigger joint injection, we usually go for 1:3, one celestone. Um, yeah, one celestone and 3 ml of marking. So this is our normal 25 gauge needle, which is 38 millimeters length, one drawing up needle, and this 5 cc syringe. So for the bigger joints and for the bigger bursa, we usually do 1:3. But for the smaller areas lateral epicondylitis and medial epicondylitis or plantar fascia or trigger finger, we usually go for 1:1, 1 ml of Celestone and 1 ml of Marken. So this is our tray. Um, yeah, so moving on to the positioning for the best, what is the best position for subductal bursa injection? Even in Australia, people are using different techniques to for the subductal bursa injection. Some people they are doing it lying down, prone, supine, but I think I've been working with the two different companies, and I've seen many radiologists doing the subductal bursa injection. But after doing all this, I think this is the best position for the subductal bursa injection. It's very easy for the patient as well, and it's very quick. So patient is just sitting on the table, and you are at the back, and what you do, the flex the elbow um, in a supination position, and then extend your shoulder, and your bursa is straight in front of you. I'll show you the picture as well. So this is the picture. When we position the patient this as is, so this is our needle coming. This is the supraspinatus and rotator cuff tendons. This is humeral head, and this is the bursa where needle is straightforward coming and injecting into. And there is the purpose of this position, that this flexion and this extension is to take the acromion away from, because acromion is present right at the top of the bursa. So we have to take acromion away from our field. So as you can all see, the acromion is not seen in this field. So this is the best position, I think, for the subductal bursa injection. This is another patient, needle straight forward into the bursa. So the bursa is filling with the contrast. This is another subductal bursa injection, again humeral head, the rotator cuff tendon inserting into the greater tuberosity, and the bursa needle. So this is, you see how the bursa is, the medicine is going into, and bursa is distending with the medicine. Another subductal bursa injection. Another subductal bursa injection. This bursa is quite big. It's all along the greater tuberosity and lesser, because the three of your rotator cuff tendons, they are attached at the greater tuberosity, and one of them, the subscapular, is attached to the lesser tuberosity. So the bursa is going along all the tendons. So it's a quite big bursa. So when you distend it with fluid will, as you can see, the fluid is going all around. Okay, so moving on to our injection around the elbow joint, lateral epicondylitis injection. So this is again the best position for the lateral epicondylitis injection. That is the injection along the common extensor tendon, and we all know that common extensor tendon is attached to the lateral humeral condyle. So patient is sitting and putting the elbow on the table, and just we can see the straight. Um, so this is the picture. Okay, so this is lateral humeral epicondyle, humeral shaft. This is the bursa. Oh, sorry, this is the tendon, common extensor tendon, which is attaching to the lateral humeral epicondyle, and this is the needle. We take our needle from here and straight at the top of tendon, we inject over there. So medial epicondylitis is the injection into the common flexor tendon. So common flexor tendon is attached to the medial epicondyle of humerus. So medial is inner. So this position, I think, is the best position to inject for medial epicondyle. Um, um, so so this is the best position, and again you can see that this is the common flexor tendon attaching to the condyle and medial humeral condyle, and this is the needle coming at the top of tendon, and this is the fluid going into. So plantar fascia injection and positioning. Plantar fascia, yeah, again for plantar fascia, the people using different technique for plantar fascia injection. Some people they prefer coming from back of the knee, but I think from back of knee is bit more painful. I think coming from a medial approach is better. So this is the best position, that a patient foot is like this, and just and your ultrasound probe is oriented transverse, and you inject from this side. And you can see this is the plantar fascia insertion at the calcaneum. This is calcaneum, plantar fascia insertion at the calcaneum, and this is the needle coming at the top of plantar fascia. Again, not into the plantar fascia, at the top of plantar fascia. So this is the ankle joint injection. It's joint injections. I think they are more pretty easy because once you touch the bone, you are sure that you are in the joint. I mean, the bursa injections, they are a bit difficult because you cannot be too away from the tendon and you cannot be into the tendon. So that's why you need to be very careful that your injection should go exactly at the top of tendon. But with the joint injection, if you know that when your needle touch the bone, you know that you are in the joint. So this is ankle joint injection. This one is actually lot of synovitis in this ankle. And okay, so next is carpal tunnel. Carpal tunnel is injection along the median nerve. As we all know that median nerve is present in the flexor retinaculum on volar surface of wrist. So this is the median nerve. As you can all see, median nerve with the nerves are usually hypoechoic with some hyperechogenic cords in it. And this is quite thicker median nerve, and this is the needle coming. So we can inject at the top of median nerve as well, or at the bottom of median nerve, whatever. Because even if at the top we are the purpose of injection is to inject deep to the flexor retinaculum. So if you are deep to the flexor retinaculum along the nerve, so it's okay. We can. Some people they prefer injecting at the bottom of the median nerve. Some people they prefer injecting at the top of median nerve. So it's the same. So trigger finger injection again. So this is our. So we'll start with this one. This is our flexor tendon. So and this is the tenosynovitis around the flexor tendon. So our needle is going into that area. Again, that needle should be in the tenosynovitis area, not into the tendon. It's along the tendon, along the synovial sheath. And here the medicine is injecting into along the tendon. So decurrent tenosynovitis. So decurrent tenosynovitis is inflammation of the tendon sheath of abductor pollicis longus and extensor pollicis brevis tendon, and is the compartment 1. So there are 6 compartments on the dorsal surface of wrist. This is the first compartment, and this is the most commonly inflamed compartment as well. So we can inject along the extensor. The bigger one is the abductor pollicis longus, and smaller one is the extensor pollicis brevis. So these are 2 tendons which are included in compartment 1, and they actually share a common sheath. So we inject into that sheath, and these injections they are really helpful. Then this is the greater occipital nerve injection. As I told you that the greater occipital nerve is always present medial to the occipital artery. So just use your probe and locate the occipital artery by putting the color code, and then the greater occipital nerve is really medial to the artery. Lateral femoral cutaneous nerve is present or at the anterior superior spine. This is anterior superior spine. This is lateral femoral cutaneous nerve, and we are injecting along the nerve, not into the nerve. So knee joint injection, yeah, knee joint injection. Some people they prefer doing knee joint injections in ultrasound, and some people they prefer doing in CT scan. I mean, it's a personal preference. Um, uh, in our practice, we prefer it in doing in CT scan because if there is a lot of fluid in the knee joint, I think then it's better to go for ultrasound because ultrasound we can see the fluid and then inject into the fluid. But if there is not much fluid present and the knee is there is osteoarthritis and but there is not much fluid, I think in that case CT guided knee joint injection is better because with the CT guided we are actually entering into the joint that we cannot enter with the help of ultrasound. So this is the knee joint injection. So we inject into the patellofemoral compartment. So this is the position of the patient, and then we mark. We put a grid over here, then we put a marker, and then inject. And we can aspirate as well. So it's a personal preference whether some people even with no fluid, some people they prefer doing it in ultrasound. Glenohumeral joint injection. So there are three major indications for the glenohumeral joint injection. That is, one is adhesive capsulitis, that's also known as frozen shoulder, rheumatoid arthritis, and osteoarthritis. So for osteoarthritis and rheumatoid arthritis, the injection is straightforward, just like other injection that we give. We can use 2 ml of Celestone and 3 ml of Marken, but with the adhesive capsulitis or frozen shoulder, we usually do the CT guided hydrodilation, because we give a lot of fluid to dilate the glenohumeral joint and to break all the adhesions which are present within the capsule. So that's a different procedure. But for osteoarthritis and rheumatoid arthritis, we can inject into the joint. And again, it's your personal preference. Some people they prefer doing joint injection in the ultrasound, and some people they prefer doing in CT scan. In CT scan, we are sure that we are in the joint, and we can actually confirm our needle position by giving contrast. We just give up one, maybe half ml of CT contrast, and we are sure that we are in the joint. But with the ultrasound, um, we cannot be sure that we are in the joint. But again, it's a personal preference. Some people they prefer it in ultrasound. And shoulder hydrodilation is a different procedure, only done in CT scan, and I'll give you a little bit of detail of that one as well. Yeah, so this is the positioning for shoulder hydrodilation. So position the patient like this, then put a grid on it, then put a marker, and this is how we give the contrast. This is contrast, and after giving contrast, we are sure that we are in the joint, and then we distend the joint with the almost almost 50 ml of fluid, because we give 2 ml of Celestron, um, 10 ml of Marken, and 40 ml of normal saline. Okay, so this were all about the ultrasound guided injections. Now moving on to the injections for back pain, that is the spine pain. So all of our spinal injections we do in CT scan. We never use ultrasound for spinal injections. So there are 4 different types of injections we perform in spine, that is fasciitic joint blocks, nerve root blocks, epidural block, and pars defect injections. So spine is a source of pain, suffering, and disability more frequently than any other part of body. And there are there are different minimally invasive procedures, including nerve block, epidural block, and fasciitic joint injection, that radiologists can perform successfully to treat the pain. Because spinal surgery is a big thing for patients, and uh, actually I have seen really good results for spinal injections, because people they are afraid of surgeries, especially in old age. Surgery is not an option for them. It's really not a good option for them. I think for younger patients with acute pain, with large disc bulge, yeah, surgery is a better option. But not many patients of younger age group they have the back pain. Most of our patients which have the back pain, they are older age group, and their back is affected by osteoarthritis, and multiple levels are affected. So in that case, the surgery is not option for them at all. So I think in those patients, it's these invasive injections they really help the patient. Okay, so what we do when a patient came to us for spinal injection, so we assess the pain and its severity, and we usually grade it as mild, and we ask the patient, okay, if you grade your pain out of 10, what grade will you do? So mild is less than 4 or 4, moderate is 5 or 6, and severe is 7 or 10. And we ask all these questions from the patient. So when patient come to us, we look at the referral. I mean, the some doctors they actually give the special levels that we want the injection at this level, but many of our referring doctors they do not specify it. They just leave it to us that because we already reported the CT or MRI of the patient, and they ask us whatever you people think is better, just do those injections. So we look at the referral, then map the pain distribution and type of pain. The pain mapping is usually done on a dermatome, on a picture. I'll show you the dermatome where we map the pain, and usually our radiographers who do this stuff. We look at the previous scan, CT or MRI, whatever available. We in Australia, MRI is not very common thing. I think maybe one of the reason that it's not it's not Medicare covered. So most of the patients, most of the spine problems we diagnose with CT scan. So we look at the previous scans, then make a plan that the 1, 2, 3, 4, 5, whatever injections we want, and then we go to patient, explain everything, and take a consent, and then commence the treatment. So pain, patient which are having pain at the back with no radiation in the leg, most likely this pain is because of fascial joints or disc bulge with no nerve impingement. There is a disc bulge, but there is no nerve impingement. If the disc is only impinging on the thecal sac or the fascial joints are blocked. So pain with radiation, that means your nerve is impinged. And if there is claudication, that means there is spinal stenosis. So this is the patient questionnaire dermatome form. This is the dermatome form which we use in our practice, and our radiographer, they actually map the pain distribution on this form. This is the compulsory part of our all the spinal injections. They map it whether the pain is more in the L5 or L4, L3, L2. They map it. This is the on this one. And the important questions you ask from that: do you have a pain sensation down your arms or legs, or buttock pain? And then questions about, are you diabetic? Because if patient is diabetic, we only give 1 ml of celestone. Otherwise, we can give 2 ml of dexamethasone as well. And if the sugar is uncontrolled, if sugar level is more than 10, we usually do not use spinal injection in those patients. And another important question to ask about any anticoagulants, because there is a if the patient is on anticoagulant, they have to stop the anticoagulant before coming for spinal injections. So these are the important questions we have to ask from all of our patients. This is the consent form. We take consent from the patient and get it signed from them. So all the side effects, they are written in the consent form. I think I'll skip this slide. This is not this is quite messy slide. Okay, so spinal injections. Patient position is prone. We'll use 22 gauge spinal needle, and the length of needle is according to the length of I mean the width of the patient. We have 7 centimeter, 9 centimeter, 12 centimeter, 18 centimeter. Then we usually give local anesthetic to skin, and we will use 1 ml of dexamethasone with 1 ml of xylocaine for most of our spinal injections. And epidural injection, for epidural injection we use pump method. I'll explain the pump method in the epidural injection. And then at the injection, at the end of injection, we usually give a pain chart to patients, and patient have to mark it that for 1 week, that how their pain is going down over 1 week. So this is pain record. The patient record their pain, how their pain is responding after the injection. So these are the guidelines which use for the if the patients who are on anticoagulants, because there are different types of anticoagulants, and the um, the time interval for which they have to stop the anticoagulants is different. So this is all our guidelines. We have to follow these guidelines according to this one. So a little bit about degenerative disc disease. I think you all know that there can be just a disc bulge which is causing compression on the thecal sac. Then there can be disc protrusion. A part of the disc is coming out and causing compression on the nerve. Large protrusion, and when the protrusion is too large and it's start disconnecting from the disc, then we call it as extrusion. And when it is completely disconnected from the disc, that's known as a free fragment, and fragments can go anywhere. Again, the disc bulge, disc protrusion, large, and this is the free fragment. Degenerative spine on MRI. This is the disc bulge, which is causing compression on the thecal sac. These are the exiting nerves. I think they are okay. So there is this patient probably having more of a back pain, not radiating down to the legs. Again, a herniated disc. So this is a herniated disc. This is causing compression on the nerve on the, and this nerve is the nerve is present in the lateral recess. Again, a disc herniation causing compression on the nerve. So degenerative spine on MRI, disc bulge. So little bit of disc desiccation. So as you can, the normal disc, the nucleus purposis is very wide on T2 weighted imaging, and this is annulus fibrosis. But with the degenerative disc, the nucleus purposis is not that wide. That means the disc water has reduced a lot, and there is a disc bulge. So disc water has reduced a lot in this disc as well, L5S1, and there is a disc bulge. So again, the same thing. This is herniated disc, which is causing compression on the thecal sac. Again, nerve impingement. I think there's nothing new in this slide. Then the spinal canal stenosis. Yes, spinal canal stenosis is caused by multiple factors like disc bulge. Then an important component of spinal canal stenosis is caused by ligamentum flavum. There is ligamentum flavum is actually the ligament which is present posteriorly, and as you can see, so this is a part of disc bulge, but this is all the ligamentum flavum which is causing compression. And there is another component, very important component, which take part in spinal canal stenosis is the facet joint arthropathy. So usually spinal canal stenosis, all three things are bad. So when there is, so when there are multifactorial, like three things are bad, what to give? I mean, what injection is better? Is it the facet joint injection would be better, or the nerve root injection would be better for spinal canal stenosis patient? Because if you are going to do the facet joints and nerve block, so that means if there is spinal canal stenosis at this level, so you have to do the right facet joint, the left facet joint, the right nerve and left from 4 injections. That's too much for one level. So that's why the spinal canal stenosis we usually prefer giving, and spinal canal stenosis, it's less likely to be at one level. Mostly it's present at multiple levels. So we prefer doing in spinal canal stenosis patient the epidural injections. Yeah, because epidural injection, there is one injection which has gone into this epidural space, and it can move along, so it can affect all the things. So it's better to go for epidural in spinal canal stenosis patients. Again, another case of spinal canal stenosis. So what causes spinal canal? I think I should skip this one. This is so planning for patients. So considering all the factors, that the factors include that what dermatomes are involved, and at the imaging what levels are involved. We decide whether we are going to do a single level or multiple level injection, or combined type of injection at single or multiple levels, and uh, preferably performed all the injections we perform on different days. We very unlike we can do facet joint injections 2 in 1 day, but nerve root injection we always do uh, one per day, and the epidural injection one per day. And after the nerve root injection, I think the most important precaution we ask from patient that they cannot drive for 24 hours, because sometimes their leg can get numb. So I think that's an important thing to be worried about. So planning for the injection, the patient is inside prone position, we put the grid in, and the radiologist outside, and we plan so what level we are going to give the injection. We just mark it on the skin, and then the radiographer will go inside and will mark on the grid the level. And this is our tray ready. So preparing for injection, or getting medicine ready, all of the medicine ready. Then cleaning the skin, just and getting ready, and this is the injection done. Okay, facet joint blocks. Facet joint blocks are really helpful in patients with Gardner's back, with stiff back and hamstring tightness, and lower back and buttock pain. And it's very important in patients who cannot stand straight. So facet joint injection. Facet joint, out of all these spinal injections, I think the facet joint injection is the easiest one to perform. Um, so this is our facet injection. So I told you that facet joint injection we can perform 2 in one day, other injections no. And this patient has bilateral facet joint disease, and so the we can inject at the same level, the level was same, so that's why the radiologist he just decided to do both levels at the same time. So this is a facet joint injection. This is cervical facet joint injection. Cervical facet joint injection little bit different to the lumbar spine. In lumbar spine, the position is pretty easy. That patient is prone, and you are going straight into the facet joint. You don't have to angle your needle that much. But in the cervical spine, you cannot use a prone position. It's usually the oblique position. So this is your spine in oblique position, and this must be your facet joint. Yeah. So this is the video. So this is facet joint, and we have to enter this joint. So this is the the cervical spine facet joint injection. They are little bit difficult because there are a lot of vessels around this area. You have to be careful that you are not entering into the vessel, and it's an oblique position. And especially the C7 when you are doing the C7, there's a curvature of the neck, and that's really a steep area to go into. So a little bit difficult cervical spine injections comparing to the lumbar spine injections. Again, another cervical spine facet injection, which you can all see. So the oblique position, and the injection is going into the facet joint. But they are really helpful. I mean, I've seen a lot of patients, they get 100% relief of their pain, especially if it is a focal level. If there is a lot of disease, then the effect would be less. But if one or two levels are involved, and we know that pain is coming from that level, then these injections, they are really helpful. Another facet. So this is lumbar facet injection. This is why I'm saying that lumbar facet injection are pretty straightforward. You have to go straight into the facet. This is another cervical spine facet injection. Again, an oblique route. You cannot go from here. This is the vessel. This is the vessel. Lot of vessels in this area, so you have to be very careful while doing the cervical spine injections. So nerve root block injections. Yes, selective nerve root injections provide pain relief in 70% of all patients and in 95% of patients with foraminal stenosis, secondary to degenerative stenosis. So that's a really good result. And selective nerve root injection often result in a degree of epidural, because when we are injecting into the nerve root, some of the injection might go into the epidural space as well, and which plays a role in pain relief. So this is cervical nerve block injection. So for nerve block injection, we usually give CT contrast to be sure that we are in the neural foramina. So this is the injection, the needle going into the neural foramina, and this is the CT contrast, which is we give CT contrast to confirm our position and to confirm that we are not into the going into the vertebral artery. That's the most difficult part of the cervical spine nerve root injection, because the vertebral artery is very nearby to you. It is present here, and you are injecting here. So we give contrast, and the contrast is going into the neural foramina. We are sure that we are at the right position, and then we inject. Then cervical nerve block, another patient. This is the lumbar nerve block. Lumbar nerve block, again, it's relatively easy than cervical nerve block, because usually the straight passage or oblique passage is okay, and we usually do not give contrast for lumbar nerve injections, because once you are in the neural foramina, you are in the position, and there's no problem, like we are sure that there is no vessel in the neural foramina, so that's why we do not use the CT contrast. So this is S1 nerve block injection. Is in case straight into this. This is S1 nerve, and we are injecting again alongside the nerve, not into the nerve. Again, a cervical spine nerve block injection. So needle like this. So we cannot come from here. This is a vessel. This is a vessel. So you have to be very careful that you are coming from the side. So this is the contrast which is outlining the vertebral artery. So vertebral artery is that close in cervical spine injection, and you are here. That's why the injecting contrast is so important? Look, it's actually, contrast is actually outlining the vertebral artery. So the next thing is epidural injections. So CT-guided epidural injections are beneficial in patients with disc-related pain, um, and deep midline ache, radiation to buttocks and thighs, and patients who cannot sit still, reduce sitting tolerance. So indications are herniated nuclear pulposis without nerve root irritation, because if there is nerve root irritation, it's better to go for nerve root injection. Herniated nucleus pulposis with nerve root compression. Then annular tear. Annular tear, it looked like the annular tear is a small thing, but they are very painful. This is what we see, that with annular tear, although there is no nerve compression, but when there is only disc bulge with no annular tear, those patients don't have much pain. But with annular tear, they patients, they are in severe pain, and I think the epidural injection give very good results in those cases. And then another indication, as I already described, that spinal stenosis is one of the indication for epidural injection, because spinal stenosis is multifactorial, and multiple levels are involved, usually old age patients. So we cannot inject all the areas. We cannot give 10 or 12 injections to patient. So we prefer doing epidural steroid injection. But again, another thing, that for the spinal stenosis, we have to be careful to choose the level, because if we choose the level where there is very severe spinal canal stenosis, then the first thing is that it's very hard to inject in that space. And even if we inject in that space, it will not, because there is very severe stenosis, it will not go above and below. So we want some injection which has gone along the epidural space, along multiple levels. So we should really select the level which is where there is less spinal stenosis. And epidural injections are really helpful in post-laminectomy syndrome. The patients who already have a laminectomy done, surgery done, and there is a post-surgical fibrosis, or post-surgical or a recurrence of the disc herniation, then definitely second surgery is not a very good option for those patients. In those patients, epidural injections are helpful. So epidural, little bit about the epidural anatomy. Epidural is outside the dura. So outside the dura, this is dura, and outside the dura is this epidural space, which is filled with a fat. So we have to inject into that space. So what happened in epidural injection? We go from the back, along the spinous process. So there is one spinous process at the center. So we go along the spinous process, either from the right or from the left side. And our needle has to penetrate the skin, and then the important thing which our needle penetrate is the ligamentum flavum, interspinous ligament and the ligamentum flavum, and so the epidural space is just after the ligamentum flavum. Yeah, so I'll show you here. So what we do, I told you that in epidural injection we use the pump method. So why pump method? So this is the center. I think that the spinous process we can't see on this image, but the spinous process was here, and we decided to come from here, from this level. So this is the ligamentum flavum is present here, at this area. We have to pierce through that ligamentum flavum and then epidural space. But the space between the ligamentum flavum and the cord is really very small one, and we can then definitely we have to be very careful that we can't pierce the spine. So what we do when we reach the ligamentum flavum, when we're piercing through the subcutaneous tissue, skin, muscles, it's easy to go in. But when we touch the ligamentum flavum, it's ligamentum flavum is the toughest ligament of the body. It's like a bony heart. We can feel it that we reach the ligamentum flavum. When we reach the ligamentum flavum, what we do, we fill saline in a needle, and while we piercing and we put the saline, while we piercing through the ligamentum flavum, we keep on pushing the saline. When we are in the ligament, we cannot push the saline, so that's give us an indication that we are still in the ligament, we haven't reached the epidural space. As long as we are in the epidural space, our saline start going in. And when our saline start going in, we are sure that we are in the epidural space. Then we inject the CT contrast to confirm that we are in the epidural space, and after confirming it, we inject into the epidural space. So this is the injection. Um, so needle is coming. So this is epidural. So needle is coming from here along, and this is right in the epidural space. Again another epidural injection. So needle will traverse from here, and then we'll cross the. This is the contrast confirming that we are in the epidural space. Or some people they don't use the CT contrast. Some people they use air as a contrast. Even one of our radiologists they use air as a contrast. So they actually push a little bit of air, and the air outline the epidural space, and then they inject. So this is the CT contrast outlining the epidural space. This is again an epidural injection, CT contrast outlining the. So this is the same patient. This is how the spinal canal stenosis was before. So it's very hard to differentiate the ligamentum flavum and the cord here. So that's why we use the pump method is really good to prevent any bad thing to happen. Another case, so air using air as a contrast, air as a contrast. So if there is sometimes these back structures are too much tightened and we cannot go from that area, then transforaminal epidural blocks can be done. Transforaminal epidural block is just like the nerve root blocks, but they're a little bit. But I think I will not go into detail of that one. That's too much of a discussion. Yeah, the next injection is past effect injection. Past effect is just like your facet joint injection. You just mark the area, mark it, and then inject it just like your facet joint. Then the injection is into the sacroiliac joint. So one important thing about the sacroiliac joint I want to share that sacroiliac joint as a whole is not a cartilaginous joint. It's only the lower part of sacroiliac joint is the joint where we can inject. The upper part of sacroiliac joint is membranous joint. So we have to be very careful that we are injecting in the lower part of sacroiliac joint. If you happen to see the lot of sacroiliitis on the x-rays, you will notice that the sacroiliitis is affecting actually the low part of sacroiliac joint, where there is a real joint. So I'll show you the video. So this is upper part of sacroiliac joint. We can't. This is the low part of sacroiliac joint. So you have to be careful that you are injecting in the low part of sacroiliac joint, which is the area which actually affected by arthritis and everything. Again, I'll show you once more. This is upper part of SI joint. No injection. This is low part of SI joint, so injection into the low part of SI joint. And SI joint injection is also straightforward. We use 1 ml of dexamethasone and 1 ml of markin, and mark the area and then inject. Again another SI joint injection, another SI joint injection. In all the SI joint injection we inject the low part of SI joint. And another injection we can inject is along the coccyx in coccydonia. So CT-guided spinal injection with steroids and xylocaine can be performed quickly with little complications and effective symptomatic relief. And spinal injections can be both therapeutic and diagnostic. So let's wind up our today's discussion. So when patient coming with pain, correlate clinical findings with imaging. And in Australia, imaging means for most of patients is the ultrasound, especially for MSK injections or MSK. MSK ultrasound is very big part of all the ultrasounds which we are performing in Australia. Imaging of all the joints and bursas, and we can diagnose everything with that. So correlate the clinical findings with imaging is very important. Then injections are diagnostic and therapeutic. I have told you that if in shoulder joint, sometimes the clinical findings they are mixing with each other, and even with imaging, little bit of osteoarthritis is there, some of the bursitis is there, some of the, and we are not sure which one of these conditions is actually more symptomatic, which one is causing more pain to patient. So therapeutic, in that case, what we do, we start with the simplest is the subdural bursa injection under ultrasound guidance. We do that injection, and if patient is pain free, that means the pain was causing from that bursa. And if not, then moving on to the other, like a glenohumeral joint injection or shoulder hydrodilatation. So injections are diagnostic and therapeutic. And imaging workup on site before doing procedures, like we usually prefer doing, even if patient came to us, they have ultrasound from some other imaging or some other hospital, we prefer doing it in our center before doing any procedure. And definitely that we are available to discuss all the patients. It's a routine in our practice that we really, the doctors call us and we call the doctors and we discuss the patient and then we perform the procedure. So take home message is, when you see a person who has pain, pain is a warning sign, not to ignore it, persist or swear. And some pains have serious underlying pathology. You should have to rule out that underlying pathology. Pain differs patient to patient and differs in body parts. And management of pain include multidisciplinary approach. I think this is the most important take-home message for today. That this is not the job of one doctor, one GP, or one specialist. It's a multidisciplinary approach, and we need to educate the patient as well, that you have to go through whole of this procedure and the multiple doctors can be involved in your treatment. So yeah, management of pain includes a multidisciplinary pain approach. Thank you very much. So I want to thank all of you. I hope uh, I would be you will learn from my experience, and I hope that I gave my lecture in such a way that it will be beneficial for you people. Thank you very much again.